Thank you very much for that introduction, and it's an absolute pleasure to be here in Thailand, and I'm really looking forward to spending the next few days with everyone, learning from your experience and hopefully sharing some of our experience as well. I mean, as you've heard, this is actually the first time I'm coming to Thailand to kind of speak from a work purpose, but this is not my first time in Thailand. And in fact, Thailand is almost like my second home. This is actually my eighth time that I'm coming to Thailand, and I've actually visited Thailand more times than I've visited the countries in mainland Europe. So I do feel very comfortable to be here. And hopefully, this is not my first time that I'll be coming to speak from a kind of a professional perspective, and hopefully in the future we can collaborate a lot more. So these are my disclosures for this particular presentation, and this is the outline of what I'm going to talk about. And as you've already heard from the first presentation, I mean, metabolic syndrome and diabetes, it's a big problem for our CKD population, for our dialysis population, but also and especially so for our kidney transplant population. So I'm going to spend a little bit of time just to give a little bit of introduction and background as to why post-transplant diabetes or PTDM is such a big issue, why we see so much of it after transplantation, and then I'll focus a little bit on the guidelines and recommendations that we have with regards to the diagnosis, but also prevention and management. And I'll base the prevention and management using some common clinical scenarios that we often face as transplant professionals. So firstly, why is post-transplant diabetes so common? Well, if you look at the risk factors for diabetes, you can split it in two different ways. You've got your non-modifiable risk factors on the left, things that we can't really change. And then you have your modifiable risk factors on the right. And you've already heard about the importance of things like obesity and metabolic syndrome. But there's another way to look at this. You can focus on the generic risk factors, and then in red, you can focus on the transplant-specific risk factors. And of all the risk factors, the biggest one that faces our transplant candidates and transplant patients is the impact of immune suppression, and I'll focus a little bit on that. Now, we all know that diabetes is prevalent all across the world, and this is the Global Burden of Disease study, and it shows you the diabetes rates across the world. And in this particular publication, it mentions kind of a 10% prevalent rate of diabetes in Thailand, but my understanding is it's probably a little bit higher than that. And certainly for us in the UK, we're seeing more and more diabetes. So not only more people with diabetes who are getting kidney failure, but even people who develop kidney failure for any other reason and have a transplant, they have a much higher risk of developing diabetes afterwards. And in our population, it's something between 15 to 20% of people who will develop post-transplant diabetes in the first year. And the thing to know about post-transplant diabetes is that it shares features of both type 1 and type 2 diabetes, but it's a very distinct pathophysiology. And now the American Diabetes Association actually recognizes post-transplant diabetes as its own pathophysiological entity. And the important things to remember are, firstly, it's a very dynamic condition, especially in the very early period after transplantation. People can go from having normal glucose tolerance to having pre-diabetes to diabetes very, very quickly. And that's one of the reasons why we've recommended in the guidelines that we avoid labeling a patient with diabetes in the early weeks after transplantation. But you can see even for the first 3 to 12 months, things are very dynamic. And then after that, even though things settle down, patients are still very vulnerable to switching between having normal glucose tolerance to pre-diabetes and diabetes. So that's the first important thing. It's a very dynamic condition. But also there's this bimodal incidence. So there's a much higher risk in the first year due to the stress of the surgery. The immune suppression burden is highest in that first year. But then even in the long term, a transplant patient will have a much higher risk of developing diabetes later on in life versus anyone else in the general population. And post-transplant diabetes is important because it's associated with adverse outcomes after transplantation. So on this graph, when we looked at the literature for what associations diabetes had, you can see that if you start at the top and you go around clockwise, the evidence base is very strong for post-transplant diabetes being associated with cardiovascular events, with overall graft loss or mortality. And as you go round, the evidence base is a little bit weaker, but that does not mean that diabetes after transplantation isn't associated with microvascular complications. It simply means that we don't have the same level of evidence base as we do in the general population. But it is associated with adverse outcomes, and it's an important condition for us to be managing. The other reason why post-transplant diabetes is important is because patients worry about it. And this is an excellent Australian study where they actually asked patients themselves, what do you worry about when you get your kidney transplant? And you can see diabetes is ranked very high for patients themselves. So it's an important condition and patients worry about it. And when it comes to diagnosis, the first thing to acknowledge is that it's only in the last kind of 15, 20 years or so that we've gone much better at diagnosing post-transplant diabetes. Because previously, if you looked at the literature, different definitions were used by different investigators. It could be who was on treatment at 30 days or 3 months, depending on insurance claims. And that's why in the publications you would get this very wide range of instances because we were all using very different definitions. And there was the original NODAT consensus guidelines that were published in 2002, which recommended that we should be diagnosing post-transplant diabetes in the exact same way as we diagnose diabetes in the general population. And the original classifications included both fasting and postprandial glucose levels. And using this definition, you can see that there's a bit more clarity, but still you see quite a lot of variation. So for example, if you look at 1 year instance of diabetes after transplantation, you still have figures ranging from 9% up to 39%. And that shows you the importance of what your local cohort is like and what the age, ethnicity mix is around the world will dictate what the diabetes rates are. But the one added thing that you can now use is HbA1c. Now, there are some good things and bad things about using HbA1c. The bad side of things is that it's got quite low to moderate sensitivity, but it is very specific and it's a very easy thing to use, especially if you avoid the first kind of 3 months post-surgery, and even between 3 to 12 months, depending on what the levels of post-transplant anemia are, it can be used with a little bit of caution. But using HbA1c is a very important and simple tool for our patients, and we certainly use it quite a lot. And so we've had the consensus guidelines published, which are international guidelines, but in the UK we also have some professional guidelines between the Association of British Clinical Diabetologists and the UK Kidney Association, and this was endorsed by our Transplantation Society. And what we recommended was that we avoid labeling people with post-transplant diabetes in the first 4 to 6 weeks. We can use afternoon capillary blood glucose monitoring, and there are some trials of using continuous glucose monitoring for diagnosis as well. Now, the oral glucose tolerance test is the gold standard test, and we will always recommend that it is the gold standard. But for busy transplant centers, busy outpatient units, it's very difficult to do an oral glucose tolerance test for all of your patients. So if you can manage it, or if you have some high-risk patients that you wish to use it for, we would strongly recommend it. But what we do recommend is that using HbA1c makes things much easier from a diagnosis perspective. And essentially, you need to use whatever works best for you, looking at the logistics and the resources that you have available. But we need to make sure that anyone who's potentially at risk of getting diabetes is picked up in the most robust way possible. And so, if we focus on the clinical challenges, we clearly are faced with several challenges when we're looking after our patients. And these are some of the common things that we will often hear. I've told you that post-transplant diabetes is a big risk factor for our patients. So is there a way that we can possibly prevent it? If we try to prevent it, but patients still develop diabetes, how do we manage that if it's the early period post-surgery, and then more importantly, long-term after transplantation? And now in the general population, the world of diabetes has been revolutionized with these novel agents. But obviously, all those new drugs which were trialed, they always exclude kidney transplant patients. So now we're faced with this evidence base in the general population, and we're thinking, are these drugs still safe and efficacious for our patients after transplantation? So I'll go through what the evidence suggests and what my recommendations are for all of these. So let's start with prevention. Can we prevent post-transplant diabetes, especially if you have a very high cardiometabolic risk candidate? Now, I showed you what all the modifiable risk factors were and also which ones were transplant specific. And I mentioned that the most important modifiable risk factor is immune suppression. And I guess we live in a really good time when it comes to transplantation, because we now have several different drugs that we can use to try and prevent rejection in our kidney transplant patients. And there's kind of a renewed interest in this area from the pharmaceutical industry, and there's several new anti-rejection candidates which are coming through for trials over the next few years. But there's a lot of literature on what the association of these drugs and the risk for diabetes are. And we performed a systematic review and meta-analysis where we reviewed all the different combinations. And you can see that there were 125 studies in the analysis, of which 124 of them were available for meta-analysis. And I'm not going to go through all the different studies that were involved, but what I will do is I will summarize what the literature tells us for all of these different induction and maintenance immune suppressants. So the literature is pretty clear that basiliximab induction is not associated with any risk for diabetes. There were some original studies that suggested that maybe there were, but I think more up-to-date information would suggest that basiliximab or Similac is fine for a risk factor for diabetes. Now, the literature would suggest that the lymphocyte depleting agents themselves have no association with the risk for diabetes, but indirectly they are probably associated with a lower risk for diabetes, because several centers that use these agents will often use them with steroid-free regimens, or they'll use lower calcineurin inhibitor exposure. Of course, we know that the calcineurin inhibitors are associated with the risk for diabetes, and tacrolimus is probably a little bit stronger for its diabetes effects than cyclosporin. And it's a dose-dependent effect. So the higher your exposure to the drug and the longer your cumulative exposure to the drug, the higher your risk for diabetes. And there are different formulations for tacrolimus now. There are branded and there's generic drugs, there's once-daily versions. There's no strong evidence that a different formulation of tacrolimus has any different risk for diabetes. But the calcineurin inhibitors are a very strong risk factor. Unfortunately, so are the mTOR inhibitors. And originally, the feeling was that perhaps drugs like sirolimus and everolimus would lower the risk for diabetes, and they could be used in this setting. But several studies, both observational studies and randomized controlled trials, have shown that actually the mTOR inhibitors have a very similar risk for development of post-transplant diabetes, just like the calcineurin inhibitors. The only drug that's probably been shown to lower the risk is the co-stimulation blocker belatacept. But even for us in the UK, we don't use very much Blatsept because of its cost association. So we have only a handful, maybe 10 patients on Blatsept, and not because of their lower cardiovascular risk. They will be on it because they have an absolute contraindication to be on a calcineurin inhibitor. But certainly Blatsept has a much more favorable cardiovascular profile versus the other immunosuppressants. There's no association between mycophenolic acid and azathioprine. And of course, everyone in this room will know that steroids are strongly associated with the risk for diabetes. So if you do have a very high-risk patient and you want to lower their risk for post-transplant diabetes, you could think about trying to modify their immune suppression, maybe give them a slightly lower target for calcineurin inhibitors, maybe think about a steroid-free regimen. And these are all sensible options. But the one thing we always say is we need to think about all the other complications that patients may get after transplantation. So as far as the guidelines go, we don't recommend that you modify immune suppression to lower someone's risk for diabetes. What we say is that you should think about the immune suppression so you maximize someone's survival after transplantation, both their survival and the survival of that kidney allograft. And if you feel that prevention of diabetes will help with those ultimate survival goals, then of course you can modify someone's immune suppression. But we always need to remember all these competing risks that our patients have after transplantation, because you don't want to give someone a steroid-free regimen so you reduce their risk for diabetes, but then make them a much higher risk for something such as rejection. And that is what the literature would suggest. So are there ways that we can reduce post-transplant diabetes or prevent it? There's an association with low magnesium levels, which is very common in the first few weeks after transplantation, especially because of the calcineurin inhibitors. However, even though there is an association between low magnesium levels and the risk for diabetes, a couple of trials have shown that replacing magnesium doesn't prevent the risk of developing diabetes. There's been some trials looking at pharmacotherapy, so metformin and DPP-4 inhibitors have been used in very small trial settings, again, not showing a great preventative effect for the risk of diabetes. There is an association between CMV viremia and post-transplant diabetes, and of course prevention of CMV is an important part of our care, so the less CMV our patients will get, the lower the risk, hopefully, of developing post-transplant diabetes. Some of the literature would suggest that receiving a living donor kidney has a lower risk for post-transplant diabetes than receiving a deceased donor kidney, and also the HLA matching is important. I don't think any of these things should stop us from going ahead with transplantation. Any transplant is better than being on dialysis, but it's important to be mindful of these risks. And I think lifestyle intervention is really important. Management of diabetes and of obesity, management of metabolic syndrome, I think is important. We did a lifestyle intervention study called Caviar, which again showed that there was some improvement in weight, but there was no long-term benefits from lifestyle intervention. And that's because if you are going to recommend lifestyle intervention, it needs to be a continuous thing. And this is where allied health professionals, physios, dietitians are really important. We need to motivate our patients to live healthier lives. So what if, despite all these things, our patients still end up developing diabetes? What should we do to manage these patients? So what happens if a patient develops diabetes in the first day or two after their surgery? So we did some work looking at what glucose metabolism is like after renal transplantation. And whenever we think of the pathophysiology of post-transplant diabetes, we've always said that it's a combination of two things. It's beta cell dysfunction and insulin resistance. And both of those two things are important. But in the early days after transplantation, the most important defect is the beta cell dysfunction. And it's the stress of the surgery, the high CNI levels that we will often see. And you can see that insulin secretion is the big problem in the early days after transplantation. And so when we're thinking about therapeutic options, when we think about what treatment to give, we need to think about our patient. We need to understand, is this early after their operation, or are we dealing with someone who's 5 or 10 years after transplantation? What's the clinical phenotype of our patients? And then when we're thinking about therapy, we need to think about what the best therapy is for that individual. And that's sometimes hard to get across in clinical guidelines, because clinical guidelines cover the population. But when we're dealing with a patient, we have that one individual in front of us. So it's always important that we try and translate the guidelines to that individual to think what is the best intervention for them. So when we're thinking about early treatment, what should we do? Well, the evidence for this comes from this study, which was called TIP, and it was done in Vienna. And what they trialed was a kind of a use of very aggressive basal insulin targeting hyperglycemia in the early period after transplantation. So you can see that the blood glucose target levels were very, very low. So as soon as somebody developed hyperglycemia, they were rushing in with insulin. Whereas the control arm was a slightly more relaxed target, and the blood glucose levels were allowed to go a little bit higher. And what they found were two interesting findings. Firstly, if you look at the black line, that's the treatment group, the first interesting finding is that everyone got started on insulin. What this means is that if you look hard enough, every single one of our post-transplant patients will have hyperglycemia, which would label them with diabetes. And this is one of the reasons why we've recommended that we shouldn't label someone in the first 4 to 6 weeks with post-transplant diabetes. It may not make much difference in some countries, but others where there's insurance premiums, labeling someone with diabetes, which may actually settle down within 4 weeks, actually has implications for them going forward. But the second important thing is you can see at 3 months, something really interesting happens. Everyone who's on treatment, a lot of them end up coming off insulin. And if you look at those patients 1 year later, they had a 73% lower odds of having post-transplant diabetes. So if you go in very aggressively with insulin straight after surgery, it almost seems like we're protecting them from developing diabetes in the long term. And there was some rationale for this. You can see that an aggressive approach with insulin doesn't really change insulin sensitivity very much, but it does show some benefits from beta cell dysfunction. So early post-transplant, I think it's very clear, you should be going in very aggressively with insulin. And often it may just be that you're giving them insulin for 24, 48 hours. Now, this was a single center study done in Vienna, and this was published in JASN over 10 years ago. And then the investigators did a multi-center study, which involved a few other centers in Europe. Now, unfortunately, the multi-center study in the intention to treat analysis didn't show any significant difference. But there was a significant difference if you looked at the per protocol analysis. So the difficulty here was that there were lots of protocol violations. And what I didn't tell you is that the original TIP study, which was done in Vienna, the standard practice in Vienna is to keep new kidney transplant patients in hospital for 21 days after their surgery. I'm not too sure why they do that, and we definitely don't do that in the UK. And I think most transplant centers don't keep their patients in as routine for 21 days. And so when they extended it out to the multi-center study and involved a few other centers, including Barcelona and Berlin, what they found were protocol violations, because when patients go home early on insulin, they were running into problems with hypoglycemia. So aggressive insulin is really important, but you do need to have a safety net and a good system for picking up these patients and monitoring them very closely in the outpatient setting. And these are the latest consensus guidelines, and the third kind of version that came out. And you can see that for post-operative hypoglycemia, we do suggest if you need to, you can use things like DPP-4 inhibitors, but we make a very strong recommendation for using insulin in that early period. When it comes to the outpatient setting, we've been quite bold in these consensus guidelines, and you can see that the general recommendation is to use things like metformin. I'm a big fan of metformin. I think we should be using metformin a lot more, even for people when their estimated GFR is less than 30. But you can see that in the guidelines, we've strongly advocated that we should be encouraging use of these novel agents, the SGLT2 inhibitors and the GLP-1 receptor agonists in our transplant patients. But there is some concern in many senses for many transplant professionals, and therefore you see quite a lot of variation in practice. Some patients are looked after at centers where there's very liberal use of these novel agents, and there are other centers where they still have some reluctance to offer these drugs to patients. So what's the evidence base behind both of these? Well, firstly, what's the evidence base for recommending these drugs to our patients? This is a meta-analysis done of all the randomized controlled trials in type 2 diabetes for all the different agents. And I'll just summarize what this tells us. It tells us that the only class of agents that has any cardiorenal benefits are the SGLT2 inhibitors and the GLP-1 receptor agonists. And if we're going to use a drug to manage diabetes in even our kidney transplant patients, why not give them a drug which can manage their diabetes but also has some benefits for their heart and possibly for their kidney allograft as well? And that's the rationale for why we think we should be using these novel agents. So what's the evidence base when it comes to the SGLT2 inhibitors? So this was published in the consensus guidelines, and you can see that there's actually very few prospective studies, and there's actually only one randomized controlled trial, and that's from Halden and colleagues that came from Norway. And it's a very small study, and it simply just looks at short-term safety and efficacy. But the real-world data and the observational data now is a lot more encouraging that SGLT2 inhibitors are safe and they're possibly also efficacious. And there's always been this concern about the risk for urinary tract infections or genital mycotic infections. And the literature would suggest that actually our transplant patients are at no higher risk than the general population. We are lucky that there are two big trials either in progress or being planned. The first one is the renal life cycle study. So this is a Dutch study which is looking at 3 different groups. It's looking at people with advanced CKD, people on dialysis, but also kidney transplant patients. And what they are looking at is whether the use of dapagliflozin improves these kind of very relevant cardiorenal clinical endpoints. They're looking for about 1,500 patients, of which approximately 500 will be kidney transplant patients. And they are very close to completing their recruitment. And what this study will hopefully give us is some information on the safety and efficacy of using SGLT2 inhibitors in a range of kidney patients, but also in kidney transplant patients. In the US, they are planning a trial called Renaissance, and I'm on the advisory board for this trial, and this is a very specific, dedicated trial looking at the use of an SGLT2 inhibitor in kidney transplant patients for this kind of combined endpoint looking at cardiovascular and renal safety. And hopefully this is a trial which, if it does get funding from the NIH, will start recruitment in the next year or so. So we'll hopefully, over the next few years, have a bit more information on the safety and efficacy. But the information that we currently have is that we should really be using these drugs. And I think it's much better to be using these drugs now rather than saying we will wait for the evidence from these 2 trials, because it will still be several years before these trials actually report. When it comes to the GLP-1 agonists, then there's actually fewer studies reported. Again, there are only a handful of prospective studies, and again, only one randomized controlled trial. And again, it's this very small study which looked at safety and efficacy over a period of 4 weeks. There's a lot more literature looking at observational data, and that would suggest that the use of GLP-1 agonists is just as safe and just as efficacious in our kidney transplant patients. Slight problem with kind of GI side effects, but they can usually be safely managed. We've been using a lot of Mounjaro, which is tirzepatide, in our kidney transplant patients, which is interesting because when you look at the actual safety advice from the company, they recommend that we shouldn't be using these drugs because there's no safety and efficacy data. But fortunately now there's several centers around the world which are reporting their experience, and you can see that, I mean, there's very few studies, only about 182 transplant patients, but the early data suggest that you do see a glycemic benefit, you do see a weight loss benefit, and from a safety perspective, there's no concerns with either allograft function or tacrolimus therapeutic monitoring. So I think we should definitely be using more and more of these drugs, not just from a diabetes perspective, but obviously also from an obesity perspective as well. So if I summarize the clinical scenarios, can you prevent post-transplant diabetes? You can mitigate risk, but you cannot eliminate the risk. But targeting certain things such as obesity would be really, really important. Thinking about modification of immune suppression, it's important and it can be very useful, but you need to be mindful of all the other competing risks that our patients have. Managing patients early after a transplant, you need to go in quick with insulin, but if you are discharging a patient home on insulin in the first week, you need to have a very good safety net system to avoid problems with hypoglycemia. And we would not recommend that you alter someone's immune suppression unless there's a very critical need. If you have very uncontrolled diabetes, which very rarely can happen and sometimes may justify switching somebody off their main immune suppression. The use of SGLT2 inhibitors, the short-term safety and efficacy data suggest that they are perfectly safe to use for transplant patients. The risk for urinary tract infections has been shown to be no different than the general population, and hopefully the renal life cycle study and Renaissance may give us a bit more information on longer-term cardiorenal benefits. And again, the information that we have available is that the GLP-1 receptor agonists, so the dual agonists, also have a very reasonable short-term safety and efficacy profile, and the weight loss benefits that we see in the general population probably translate to a kidney transplant population as well. Unfortunately, there are no large randomized controlled trials currently happening using these agents, but I think the evidence base that we have just now is that we should be using more of these novel agents in our patients. And just to finally finish off, there's some recommendations and guidelines out there. This is the British kind of guidelines between the Diabetes and the Kidney Association group. This was published a few years ago, and we're going to be updating these guidelines, and these are freely available. These are the latest consensus guidelines which were published, and these are guidelines looking at just the management of diabetes in patients with CKD, a lot of which will be relevant for our kidney transplant patients as well. And again, we should just always be mindful of what's happening in the general population, what the recommendations are for type 2 diabetes. A lot of that information can be safely translated to kidney transplant patients. Of course, kidney transplant patients are never in those original trials, but I think we should not deny our kidney transplant patients some of these fantastic drugs which are coming through, and I think we should just be extra careful, but most of the time the safety and efficacy profile is perfectly satisfactory. And with that, I'd like to thank you for your attention. Thank you.
That was excellent. And let me start first with my questions, and then I will ask the people from the floor to ask you. I think you address very important management of post-transplant diabetes, and it's already clear that the definition of PTDM is already clear nowadays. You mentioned about metformin, which also my favorite drugs. But I think we have not much evidence for post-transplant diabetes. Please tell us more when and where and how should we begin to use metformin, because it's cheap, right?
Absolutely, and I'm a big fan of metformin. I think the only reason why there's a recommendation for using some of these newer agents is because of the added cardiorenal benefits that they have. But clearly, depending on the resources and the cost of the medications, we need to do the best we have with the available resources. Metformin, I think, is an excellent drug to use if some of these other agents are not available. Obviously, there's restrictions with regards to the estimated GFR, and that's why often these drugs are not used in the early period after transplantation. Now, I've published on this, I don't believe in this eGFR restriction of 30. I'm not a big believer of metformin causing lactic acidosis. In cases of overdose, yes, of course, metformin can cause lactic acidosis. But I mean, I think we're all familiar with, when you see a patient in the emergency department and they've got sepsis and their lactate levels are high and they're very dehydrated, and they happen to be on metformin, and instantly you think, oh, it's the metformin that's caused it, and ignoring the fact that you have a very critically unwell septic patient in front. So I'm happy to use metformin quite early after transplantation if someone's eGFR is improving. Even if it's not reached 30, I think it's perfectly fine to initiate metformin. The one thing I absolutely dislike are the sulfonylureas. I don't like the use of things like gliclazide or any of those medications. I don't think they're very good drugs to use, and if anything, there's a suggestion that they are actually associated with cardiovascular risk as well. So I think using insulin in the early period is important. Long term, I think metformin is a perfectly reasonable drug to start, and it can be started, personally, I would say, even if the eGFR hasn't quite got to 30. Because obviously we look after these patients quite frequently. They are coming back for routine follow-up. So having somebody with an eGFR between 20 and 30 who is on metformin, I think is perfectly reasonable. But if you do have access to the other drugs, then they are really important. And we would recommend that SGLT2 inhibitors are maybe better for people if they have some coexistent heart failure or if they have proteinuria. And the GLP-1 agonists are very, very favorable for people who also have some obesity as well.
Thanks very much. I think this is very intriguing research question for Thailand as well, because we live in a country that has not much resources. And nowadays, I believe metformin is very prescribed in post-kidney transplant patients in our country. So, yeah. So let's go for the floors. Is there any questions for Professor Adnan? Dr. Thidarat, would you like to ask any question?
Thank you very much for a great talk. I'd like to ask you some questions about obesity and PTDM. For the obesity, can you give us some for the guidelines to you? What is the BMI that we should keep, and when we should start for the GLP-1 to decrease for the weight, to decrease the obesity? Thank you.
So yeah, I mean, obviously, obesity is such a big problem, and it's a barrier to transplantation for many in our country. And then, even if we get them to transplantation, gaining weight in the first year after a transplant, I mean, we see over half of our patients gain weight in the first year. So we're dealing with quite a lot of obesity. When it comes to BMI, I mean, when it comes to, for example, for transplantation purposes, we used to have a BMI cutoff of 35. We've removed that now, and what we will normally say is it's essentially what our surgical colleagues feel happy and comfortable with. And we have some patients who may have a BMI closer to 40, but their body build is actually perfectly fine for surgery. And we have some people, often it's our South Asian population, and we have a large population in Birmingham where their BMI may be closer to 30, but they have a lot of central obesity. And that is a much bigger problem for our surgical colleagues. And there's a big push for us now in the UK to not restrict transplantation to these patients. So we will encourage them to try and lose weight. Lifestyle intervention is very difficult. I mean, it's difficult for us as well. And we are using GLP-1 agonists, and we are using things like tirzepatide in dialysis patients, and often quite successfully. And then we will give them a 3-month, 6-month period. But at the end of that, whether it's been successful or not, often there's a sense that we should still give them an opportunity with transplantation, but they will then be counseled that they're a much higher risk for complications. And we do see complications, wound problems, wound breakdown, and that can sometimes be very, very difficult to challenge. So I think targeting obesity, I think, is really, really important, not just from a diabetes perspective, getting them transplanted, but all the other problems that kind of come with it. But the difficulty is that we do need to change behavior for patients. I think drugs only work a certain amount. People need to change their kind of lifestyles as well, and it's easy for us to say, but it's actually very hard to encourage people to do that.
Dr. Kanita.
Hello. Thank you, Professor. I would like to ask some short questions about how in your country reimburse these kind of novel drugs. Right now, I think our nephrologists here in Thailand, everyone has known about the benefits of the SGLT2 inhibitor and also the GLP-1 agonist. But right now, the price and financial status of the patient is one of our concern when we needed to start the new medication, even though we are knowing hard that this medication benefits our patients. So what is your condition on your country, your hospital, and how the patient deals with this problem?
Sure. Yeah, I mean, that's a very good question. And it's always important, especially when I'm kind of speaking around the world, that it's fine to kind of make these recommendations, but then it needs to be very specific to the country and the environment that you're working in. I mean, when it comes to the UK, if a drug is approved by NICE, that's the National Institute for Clinical Excellence, if it's approved by NICE, then there will be reimbursement for that drug. So patients themselves with the NHS will not have to pay for these drugs. With that, though, there is a little bit of a difficulty because obviously a lot of these novel therapies were tested in non-transplant patients. So the approval for the drugs is for non-transplant patients. So when we sometimes prescribe these drugs, or we'll ask someone's primary care doctor or their family doctor to start these drugs. So if I wanted to start metformin in one of my transplant patients, I would write to we call them general practitioners or their family doctors to say, can you please start metformin? And they will. But if we were to say, can you please start this patient on an SGLT2 inhibitor or a GLP-1, some doctors are happy to do it. Others may say this is a transplant patient. They are outside of the approval. So what we're trying to do is, essentially what I would recommend is, I think it does take a lot of lobbying from us as the professionals to try and convince the people who do the reimbursement why it's such an important thing. And certainly when it comes to SGLT2 inhibitors, I mean, I completely agree with the opening kind of statement that, prevention is better than cure. And in the UK, Kidney Research UK, we're just talking about how chronic kidney disease is such a big public health burden. What can we do to prevent it? We should be using more SGLT2 inhibitors in our general population. We actually have now started to use it very liberally post-transplantation. So people with proteinuria, people with recurrent glomerular disease, we're using SGLT2 inhibitors, even if they don't have diabetes. And we've found it to be kind of really effective. So I think it is a little bit easier in the UK. It's not completely without some difficulty, but essentially what we do is we're lobbying. We are trying to advise, because essentially what we have to say is, the investment is the benefit of the investment is that you see less graft loss, you see less dialysis, and obviously that's a lot more expensive. And that's usually what we try to do for all these things.
For the last question, Professor Kliang, please.
Let me add a little bit to Dr. Kanita comment about the enlisted of the drugs for reimbursement. In Thailand, we have 3 public funding schemes. The main is about the NHSO for universal coverage. And to use the drugs, very expensive drug, it has to go through another committee we call National List of Essential Medicine. In that case, any expensive drug can go through the evaluation, what's so called cost effectiveness analysis (CEA), and any drug medication that above the 3 times of the GDP per capita should not be too expensive for the country to absorb. So therefore, the drugs that approved in the NICE guideline or in the NICE in the UK depends on the GDP per capita of UK, which is much higher than in Thailand. Therefore, but I think that in the case of SGLT2 inhibitor, sooner or later it will be enlisted very soon. The point is that we cannot approve the drugs enlisted in the NLEM just for the kidney transplant recipient, because it will be something like a double standard. Thank you.
Yeah, and I mean, obviously there will be some generic versions coming through as well. But yeah, I mean, you're absolutely right. You know, and the cost of some of these drugs is like IgA nephropathy. I mean, there's a new drug coming every month. We're not using them because they're just too expensive. And you know, but it's nice to read them in the published journals. But I just think I'm never going to be able to offer this to any of my patients because it's so expensive. So I think, yeah, it's making the best of the resources that we all have.
Well, thank you so much. Because of the time, maybe that should be a short question, please.
So sorry. Thank you for a very comprehensive talk. I am a general nephrologist. My question is very fundamental. So the definition that we're talking about post-transplant diabetes is include only de novo diabetes, or we also include the diabetes that recurrent after the kidney transplantation. In that case, the nature of these 2 separate entities different, or you approach to these 2 different entities differently?
Yeah, it's a very good question. So post-transplant diet. So originally, and you'll still see some of the literature talks about no DAT, nuanced diabetes after transplantation. And when we did the consensus guidelines 10 years ago, we changed it from no DAT to post-transplant diabetes. And the reason for that was the thing about no DAT is half the time when patients are coming in for their transplant, they may actually have already had diabetes. We've just not been very good at picking it up. And that's why we changed it to post-transplant diabetes. I think the management is no different. And for someone who comes in with diabetes, what we'll do is we'll counsel them that, you know, that they will see a deterioration in their diabetes control. So you may come in diet-controlled diabetes, but you may go home on oral agents or insulin. But the management, and I think in the consensus guidelines, we do have a little small section to say that a lot of the advice for post-transplant diabetes is just as relevant for people with pre-existing diabetes. But they're just far more likely to end up needing insulin. They're also far more likely to actually be discharged home with higher treatment than what they came in. And we will counsel those patients accordingly.